bear hug. And this is where I get a little particular. I want your arms on the outside. Okay, I just always come over and spring them. Okay, so I can do one of two things. Find, get them here. I can say, okay, go ahead and do a bridge. Okay, relax. And I can do that sort of approach, like from bottom to top, get them localized and then drop through it. Or it's a little bit more tricky. I can bring him in. I can lift his head up. And I can manipulate him that way.
Can you just ask them to lift their head up?
You can, but what's the problem if I've asked him to raise his own upper back and body up? There's resistance, right? So I probably wouldn't do that. I try to do more of the, it is a lot to coordinate, but I think that's where you can also look to pre-position. I cannot talk today. I can put them into flexion already. So if you have tables that you can pre-position them, that's great. Bolsters, pillows. Try to do as much setup as you can without having to twist yourself up. It makes life a lot easier, but those are just two simple variations. I like the bridge in my younger, more mobile patients because then it engages them a little bit, but you do have an active component there, so you have to keep in mind. What I find a lot of times, if I get someone that's stiff spine like myself or Dr. Nichols and they can tolerate it, get them into that bridge position, and if you get the forces just right, they'll self-cavitate a lot. You'll see a lot of self-cavitation in the T-spine just because people are so hypomobile. You get enough compression and pressure and you'll find that a lot of people will cavitate before you ever even get to it.
Can you just show them how quick the hand placement treatment is?
Sure. So if I was going to manipulate his, standing on his right side, this side, okay? I'm going to get him in that rollover position. Okay, if I was going to do spinous process, it would be here. I drop just off the spinous process to the transverse process. Get him in that position. And then, it's not the most comfortable position. And a couple of you made a couple good points. Okay, you do get a lot of forearm compression and compression through the wrist and through the forearm. It's normal. That's why you try to minimize how much I have to have them rolled over. So when you get ready to apply that final compression and roll them over to do the technique, it should be game time. You should be done fiddling with your hand placement and the setup, roll them over, drop down, do the thrust, and move on to the next technique. The longer that you're trying to sit there, it's awkward, it's gonna put more strain on your wrist, hand, and forearm. A couple other things that I noticed, and I'll ask for other input too that other people saw. If you're smaller and you have a bigger patient, you can look at a couple different things. You can try to set up as much as you can. You have the positioner, so I'd say that would be an option. One thing I've seen before as well is take two tennis balls, put them in a sock and tie the sock off so it's like a really tight two balls together, and you can take that, put that on either side of the spinous process and essentially recreate that, that same concept as that positioner. It's a little softer because it's a tennis ball. And sometimes it's just abandon the technique. You know, if you can't get in a position that's safe for you and for the patient, the last thing you want to do is have to go see another PT or a chiro or a DO because you put yourself in a really awkward position trying to treat someone else. And it happens because, you know, think about it, I'm getting in an awkward biomechanical position to do this technique to begin with. So you want to make sure that you're not putting yourself at an adverse position because you are going to be flexed and rotated and all that good stuff. So.
Can you go into the bridging part of it?
Sure. Okay, so go ahead and bend up for me. So what changes with this approach to this technique? Okay, we're getting a little bit more extension, but all I'm doing is engaging him actively. The setup of the setup is exactly the same. Okay, I'm still going to get in that same position. Okay. Here, okay, go ahead and do a bridge. Okay, right there. And then drop down through. Okay, and then the only thing I'm really changing is my direction of force, right? So I can move his elbows superiorly or inferiorly as he's doing that bridge, and when I feel kind of what I think is the apex of that force over my hand, that's when I'll drop down and deliver that thrust.
So they stay in the bridge?
In the bridge. So there's a little bit of an active modification to it.
So I would just add that, so this whole technique is all about using your hand to side, your hand is the fulcrum. So you're gonna flex them up to affect the teeter-totter. You can lift their bottom to affect the teeter-totter, but what you're feeling for is the most amount of pressure on your hand, and then you know it's game time. That's what the flexing and then the bridge is doing. It's just affecting how you feel the pressure. Maybe, yeah.
So are there benefits to after you roll them over to kind of rock in a little bit and kind of playing with it a little bit before you go ahead and do the thrust?
I would say no, because you're losing your compression. One thing I think a lot of you will find is you may have had a great setup, but as you get into the roll and into the application of that force, there's a couple of mistakes that I see a lot of people make. You should lay down. I'm not actually gonna mean to, but okay, so I get all this set up and this all looks good, okay? I get here and I get them all set up to here, and then a lot of times people will come away from that and try to get that compression back. So you're committing to it, I'm gonna do it, and back off a little bit. If I'm here for too long, my hand goes to sleep. And if I'm wiggling my hand too much in that position, I just feel like you lose your compression. So I think by the time you get to that point, it should be game time. You find where the most force is, you thrust, and you move on. If they cavitate on the way over, I still do the thrust just to make sure I've gotten everything I want to get out of that. I don't know if you guys have a different opinion, but
Yeah, the only other thing I would say is seeing a lot of you guys is you're just kind of trying to flow through your manipulation. You're not really, am I there, am I feeling it? But one of the things that I will do is I will take the patient, I'll have them breathe in, breathe out, and I'll put that force in, I'll take them to end range so I can feel where my barrier is. And I'll hold that there, have them breathe in again, and breathe out. And as they're exhaling, I'm gonna push through that barrier again so I know that I'm locked into that joint. That way you can actually feel it. Because if you don't feel locked in, you don't really know what you're holding on to or what you're going for. So that's just kind of a quick little tip for that.
The rib one, I had a question myself, just on your pin placement, was your whole hand biased to the side of the spine? Okay. I don't know if you guys got that, that's a little different than what I do, but, so he's moving, he's creating the fulcrum now on a unilateral side of the spine to focus on the rib. Put that over the top of the rib.
other questions at all about the application, how you change it a little bit. So play with both of those. Try flexing from above. Try having them do a bridge. I think those of you that have had trouble with that, getting that arm wrapped around your patient, the bridging will be a lot easier. It's a lot less. And if you still have difficulty, use the table to pre-position them, either with pillows or get the head of the table